Hi, welcome to our new podcast. It's called Old School, New School, Paramedic Podcast. I'm here with KJ, with my co-host.
Jason.
God damn it.
Your father.
I am your father.
Yeah, they're going to know.
I know they're going to know. I'm just
so,
going to... Do I do my full name, or like I'm Kristjan Joelson, or can I just go by... Everybody calls me KJ, so...
Well, I don't know. It's whatever you want to do.
Well, then I'll do
I'm
KJ.
Jason Joelson.
I know you're Jason
I go by
Joelson.
whole name.
Okay, I'll go by
Sounds like a song. Anyways,
anyway, we're gonna have a huge blooper.
This is actually how the intro is going to go, and I'm going to keep it.
You gonna keep this?
Yeah.
Okay.
It's Old School, New School Paramedic Talks. I've been a paramedic now for about 34 years, and Advance Care Paramedic in Alberta. And this is my son, who recently just got into it in December as an EMR. So you want to explain to people what an EMR is in Alberta?
An EMR is emergency medical responder. It's the first level in our level of trees, I guess you could say. Next would be Primary Care Paramedic, or PCP, and then ACP, as my father is here. Though I did start technically in November. I got hired on AHS in November, and I've been in EMR, so about 7 to 8 months now. I think we're on 8 months.
Yeah, it's about that, 8 months. So what kind of truck do you work on?
I work on a truck that's called a net van. Recently it's been changed to net. It's now non-emergence transport. Basically, I do transfers from hospitals to other hospitals, getting people to appointments or getting people home. The patients that are usually in my truck have to be pretty stable. Used most of the time, it's taking elderly home or people back to their care facilities. So it's not too demanding, but it is still quite a mental tax.
Well, the NAT vans, being in the industry this long, I've been an active supervisor. Now I'm doing a clinical educator in Alberta Health Services. But the big thing about the NAT van is that it does clear up space out of the hospital. So you get those patients that are still in the hospital that need to go home, but they don't have an actual ambulance that can come get them. So they use these NAT vans, and they actually create their integral part of the system, because they can move 20 to 30 people a day that creates space in the ER. So even though you're starting at that bottom level, they make such a huge impact actually in the system for the day that a lot of people don't understand. So what kind of training did you have to do to get there?
Well, I did about a year's course for the EMR to get there. And then after a couple months, here in Alberta, there's a copper exam every 2 to 3 months. So I had to write one of those, get my license, apply to Alberta College of Paramedics to get a license. Once I had my license, then I applied to the opening.
All right. Well, let's just make sure everybody understands that when you did your course, it's kind of it was through NATE, and they do it in the evening, so it's a con ed course. So the idea is that you can go in the evenings. It's spread out through a lot of time. So if you actually went to school, taking your EMR for a full 8-hour day kind of course, you're looking at about a month's worth. But it allows you to get in the system and still keep your job and be able to pay your bills.
I was, because I worked as a lifeguard and a bike mechanic as getting my EMR, which was nice because it was at night, so I didn't have to worry about making time for it.
And you went through your EMR course during COVID, so you did most of your stuff online.
That was rough. It was pretty rough to go online 24, most of it, because you would learn 9 hours worth of skills, and then they'd give you 3 hours worth of time in class to practice it, which I mean is kind of a struggle with COVID. So
the problem with this job is that it's a touchy-feely job.
Yeah, it very much is.
You got to be willing to touch people. You got to do your assessments properly. And when you're doing COVID, you were doing it online, so it's really hard. So it's really hard to touch people through a camera.
Well, and on top of that,
as creepy as that sounds.
Yeah.
Right?
It's also hard because you don't have even when we were in class, you were always using a dummy, right? So it's hard to even when you're just doing a visual assessment, it's a dummy doesn't give you feedback. Right, as a person, you move around, and I can wave at you, and you can wave back at me, or
if you're spurting blood, you can see the blood pooling.
Yeah, that too.
The idea that so when you're going through school, the scenario testing or the scenarios that you do are really tough. So that's part of this idea, old school, new school, is that we're going to kind of document the idea of the idea. I remember you saying to me a while back that you were getting into it, and I was on my way out.
I mean,
Which
I'm not
I'm not on my way out yet, but hopefully I get to retire in this industry, which is very, a lot of people don't. So over the next little bit, we're going to check in once in a while and see where Kristjan's doing, how he's doing. You did get into PCP school.
Yes, I am. I'm headed to PCP school in January.
What does PCP stand for? So when we're talking about it, Alberta changed. We used to have EMTs and paramedics. BC were kind of similar throughout Canada. If you look in the States, we used to run with EMTs and paramedics. Now we have EMR level, which is your basic level, which Kristjan is, which is emergency medical responder. Then we have your PCP, which is your primary care paramedic. And that is actually truly almost a year's course. The next one is ACP, which is a 2-year course. So the difference between the three really is the ACP in Alberta. We are very highly trained. We kind of run in more of the critical care. We do intubations. We actually in Alberta, in Edmonton, we thrombolize. So if we come across someone that is actually having a heart attack and they show ischemia, and we actually do a 12-lead talk to the heart and stroke doc, we will actually get permission to thrombolize the patient. At the primary care level, they are giving certain level drugs like Gravel now, Advil, and they are allowed to start IVs. And again, the EMR is just the basic start. But you did get into PCP school, and that's huge.
Yeah, I am headed to PCP school.
So a couple things as we go through this. This is our first one. It's kind of the introductory podcast. What we're going to do is talk about some things that you may never heard of before. I'm going to ask you this question have you ever heard of mask pants before?
I have not. I don't know what mask pants are. Is it masked like MAST, or mass is like church?
Well, it's MAST, and I'm sure I don't remember the abbreviation for them. So there were these wonderful pants that we used to have. And what we would do is we'd come up to people and we would put them on them, and they strap them on. And it's like, if you think of a fighter jet pilot, right? They have those pants that used to compress their lower extremities to push more blood to their head. So it's the same idea. So we would come in, put the pants on their bottom half, their legs. So if they had trauma to their legs, you couldn't do it. But we would pump the crap out of these pants and put a bunch of pressure. And the idea behind it was it's going to push more blood to your vital organs, your brain, and that kind of thing. It did increase your blood pressure a little bit, but really when they found out, it wasn't really doing anything. And the worst part about it is when you got into the hospital with a patient with some mask pants on, you look over and sometimes the nursing staff and the doctor didn't know what they were. So right away they wanted to cut them off, and they would start cutting them, and they would let all the air out of them really fast. And that would really tank the patient's pressure, and sometimes even kill them. So when we were using them, we had to be really diligent when we were in the hospital. We had to be on top of them to make sure they didn't cut them. So because there was a certain way to turn them down to get the air out. So
to like release it so it doesn't
slowly
drop their pressure.
Yeah, while you're giving them fluids, right? Here's the thing for you. What kind of stretcher do you use? The ambulances that we have in Alberta, what kind of stretcher we have?
We have a power cot from Stryker. It's a yellow one that's automatic. We have buttons, and they go up and down for us, which is really nice because it means one person can operate the stretcher while somebody else is, either attending to the patient or moving some stuff around. However, in the ambulances in Alberta, we have something called power load, which allows the stretcher to actually lock into a piece, and you hold the button and it raises up and basically levitates them, and then you can slide them into the ambulance. So there's no having to struggle to lift. But as a NAT van, we actually still have to lift because our NAT vans can't take the power load. So we're most of the time lifting all day.
So you're getting your workout at work. Kind
Yes.
of. Yeah. So you're still doing the lifts. Power loads, we've had them in Alberta now for over 2 or 3 years now. It's made a huge impact probably on our injury prevention, especially backs. It's the coolest thing. But the question I have for you is, have you ever heard of prior to that, most people would know is the stretcher that you put the 2 wheels right on the deck and the one person lifts, and that's kind of what you guys are doing now.
Yeah.
With the power loads, and then somebody would grab the wheels and jam them up. But have you ever heard of a 2-man stretcher?
No.
At all?
No.
Ever use one?
Nope.
All right, so think of this. 2-man stretcher, at least it was multi-level at the time that you could raise it up and down. But to get it into the ambulance, you had to lower it at the back of the ambulance all the way to the ground. You and your partner had to grab the right bars, because you want to grab the bottom cage of this stretcher. And then what you would both do at the count of 3, you both have to stand up at the same height, same level, and you're going to carry all the way to the stretcher, all the way to the patient. And now you got to lift that into the stretcher. So you wonder why back in the day you hear about how EMS people were losing their backs, and that was probably from the 2-man stretcher.
I am going to clarify. He said lift the stretcher into the ambulance, not stretcher into the stretcher.
Did I say that?
Yes, he did.
Yeah, you're lifting the stretcher into the ambulance.
Yeah, ours isn't like
so now,
that.
So when you look at the old school, new school, like where we've come, right? They were saying like the average year in EMS was back in the day was like 6 years, but injury wise, it could easily take you out because of equipment like that.
Yeah, and I mean, there's a lot of lifting. There's a lot of funky moves in EMS. It's not as cut and dry as like picking up a box, like a heavy box, and you just, you can brace and everything, because we're never lifting people in something that in a perfect condition. It's always kind of like scuffed, right?
Well, and the thing is, like, of course, I do a lot of teaching in L&D. We teach about how to lift things, and and another catch that the reason I'm pro this power load stretcher is that, especially if you have the lifting capability in your truck installed, it saves people's backs. The next level they came to throughout the years was this 1-man stretcher for loading.
And it's awesome. I love it.
No, the 1-man stretcher.
You
You never heard of a 1-man stretcher? See, this is the old school, new school part that we're going to talk about. And basically what we're going to do is we're trying to get some experience transferred over to the new people, and we're going to learn lots from the new people on them going through and learning how can we make it better, easier for them to survive in this chaotic industry. So the 1-man stretcher only had 2 levels, right? So either you were at full height where the patient was for loading, or you're flat in the floor.
Okay.
So which really sucks because you're always hunched over. But the trick about this stretcher is you would run it towards the ambulance as fast as you can. And when the front wheels got onto the ambulance, you had this lever you would pull, and you'd hope to God that carriage underneath would just collapse underneath the stretcher, and you would slide the patient into the thing.
That seems dangerous. That seems like an accident waiting to happen.
So you can even think of the differences in moving patients, right? Like just the stretchers alone. So we've gone from a 2-man stretcher where 2 of you had to lift them all the time. If you were actually paired up, this is why people like working with people the same height. If you and I even paired up on a 2-man stretcher, it would be really difficult. Because when we went to stand up, our arm lengths and our hands would be at different positions, so it makes it harder to lift the person in. When you're looking at the 1-man stretcher, the one where you just jam it in there and the legs fold underneath, you only have 2 levels. Either you're at the top height, or the stretcher's actually collapsed onto the floor. So again, you're lifting from the floor. It's kind of those crazy things. And then if you look at mass pants, rumor is there's a little resurgency going on. I heard one school, somebody's going on that how mass pants need to come back because it's going to make a big difference. And I'm pretty sure we're using evidence-based medicine. If they do show some improvement, I'm sure it might help. In the hospital, they have a disposable kind of style mask pants. Can't really talk about them, but after surgery, if somebody's not doing well, they kind of have this pants that go around their legs, and it basically inflates and deflates, which just creates circulation and stops the idea of clots forming. And
I think the other difference too is with where I'm starting. I'm starting as an EMR level in inter-hospital transfers. I spend a lot of my time in hospital units. I don't spend a lot of time in the ER. I'm mostly upstairs in the hospitals, moving patients from one bed to another to my stretcher, and then bringing them to a different hospital unit. We do pick up from the ER once in a while, but I spend a lot of my time. So I get to see a lot of the equipment that the hospital uses.
Yeah, they actually got this thing called
it's called the TAPS machine.
Is that the hover lift?
So this TAPS, it's called a TAPS machine. It's a big blue sheet that goes underneath the patient, kind of like a mega mover, if
you know what a mega mover is.
It's
a sheet.
It's a big sheet with handles on it that you can pick somebody up. So they have a mega mover, but this mega mover actually connects to basically a pump that puts a bunch of air into it and it inflates like a giant, like an air mattress with handles. And it is so nice because it just takes the weight of the patient and makes it like nothing. And you can just slide it over.
Yeah, they have a hovercraft for patients, just so you know, in the hospital.
Yeah.
I was teaching a little while back, a course called It's Your Move, and the inter-facility guys were talking about this. I mean, it's funny because I've always worked at the emerge side most of my life, We have all these fancy stuff to move patients. It's interesting talking to the NAT vans. We have stair chairs, we have lifting belts, we have lifting seats, we have the Mega Mover. And if you think about the NAT vans, most of their job is lifting people. And how many things do you guys have?
We have a Mega Mover.
Yeah.
Yeah. So, and the reason being is I was explaining is it has to be safely able to be secured. And our NAT vans are like a GMC Savannah van. And then we have one brand new one, which is a Ford Transit. And that's the unit I'm on. I really like the Ford Transit because I can stand up in it. However, the GMC Savannah is like you're crouched like this the whole time, and it's rough. But you can't secure anything inside there, so they just don't give it to us, which is kind of nice when we go to the hospitals, and we're always excited to take their equipment.
Yeah, it's amazing what's out there. So, I guess we're gonna have to maybe wrap it up and talk about some future stuff. We're gonna talk about different calls throughout the rest of this. We're gonna talk about different techniques. We'll talk about like situational awareness. Maybe we'll talk about different types of thing. I don't know.
Well, we'll just go over
and
stuff.
just the experiences of getting into this job new. Like it's really crazy when you think of where we started. You took your EMR course, and now you're working for a large company, which is Alberta Health Services, working on that van. And I started as a lifeguard with a class 4 driving an ambulance, to the point where basically they showed up at the hospital, the rural ambulance showed up at the rural swimming pool, and they're like, who put that guy on the spine board? And I was like, I did. They're like, you want a job? And I'm like, for real? And they're like, yeah, go get your class 4. So I got my class 4, walked in and went, I got my class 4. They're like, well, the keys are there and the trucks are out there. Good luck. And they gave me a radio, and that was the end of it.
Yeah, see, if that wasn't mine, I had to get a license, had to make sure that I was,
Qualified. Yeah, I know. It was pretty crazy. And you know what my first call was? A transfer.
Well, I
didn't know they did transfers. We got to the hospital, and I thought we took emergency people, like injured people to the hospital, and didn't even know that.
Well, I think the plans for this podcast is mostly just to be a slightly educational, give information.
Yes, use the word slightly.
Slightly. It's mostly meant to be kind of have fun, like discussions about where I am at, where he's at on the way out.
Yeah, I heard that.
I know, but give us insight of how his experience has been in his career, and then how that can influence my career or help, or maybe there's something that I know that he needs to forget.
Yeah, well, and what's going to be really good is he's going to school, and you're the smartest you'll ever be is when you're in school.
That's true.
It's like when you get a paramedic student or ACP student, and they start asking you all those questions, and you know what you tell them? I want you to look that up and come back and tell me tomorrow. Give me a little presentation. It's really because I have no idea what he's talking about, but at least I'll learn tomorrow and pretend I know what I'm talking about.
Well, and I think that's another big thing about this whole job is be willing to learn and learn from everybody, right? You're never the pro. Sometimes you might have to be, but learn from everybody, because everybody's got different experiences. Everybody's got different ways they do things, and some people are better than others in one regard, but then somewhere else, somebody else has some sweet trick that works like that.
Yeah, and that's the big thing, right? Everybody has little tricks that work.
And in school, right, like there's scenario land, right? Scenario as everything runs perfectly, and you'll write everything. In real life, it's a little more funky. Try the best to obviously follow your protocols. Don't askew from those. But in your scenarios are probably not going to go how being out on the road actually goes.
No, but what it does is
it gives you the base.
I know that we're getting off topic, but and I keep telling people this: the scenario is a systematic approach. Yes. So when the
scenario gives you the ability to
when you don't know what to do anymore, you go back and go step by step through everything you've been trained, and that training is what keeps.
Well, and if you have your scenario going, right, and you have all your seats, and you've been able to go through your scenarios 100%, now you have a flow chart. So when when you're actually on call, you know where you're supposed to go. So if you can help, figure it out, like if if your patient can't talk to you, you got to figure out because they, I don't know, or have a language barrier or don't communicate,
or they're dead.
Well, I was thinking more like put your hands up, like can you count, like.
Oh, okay, I see what you're saying. I was thinking dead.
If you're rating a pain scale and they don't talk to you, but they can sign to you,
you should be bagging them.
Well, yes, if they don't respond at all,
You poke them and they don't do anything. It's probably a good thing to start opening it their way. But
yeah,
just
but
saying.
as an advan, if I show up and that my patient doesn't respond to me,
It shouldn't be your patient.
Yeah, that's usually a bad thing.
All right, so let's wrap her up. And this is the intro. We don't know what's coming next, really, but we're going to try to get another one out
soon.
Yeah, maybe slightly educational.
Yeah, it's just like I think it's mostly.
It's more fun. It's more just the idea of how we're going to get Kristjan to stay in this industry longer than 6 years, kind of thing. All right.
How we keep him so that he can make it to retirement.
Yeah, because I might need a walker in the next week. Anyways, that's it.
Yeah.
Have a good time.
Goodbye.
Bye.